welcome everyone to the webinar again, and introduce Raina, or Dr. MacIntyre, who is the Principal Research Fellow of the National Health and Medical Research Council, which is Australia's peak body for supporting medical research. So Dr. MacIntyre's research falls under 4 different areas: personal protective equipment, vaccinology, epidemic response, infectious diseases, and bioterrorism prevention. Dr. MacIntyre has led the largest body of clinical research on face masks and respirators for frontline healthcare workers internationally. So this is a topic that we're all very interested in. It's very timely, and we're really grateful to you, Dr. MacIntyre, for presenting.
Thank you. Talk about transmission of SARS CoV2, because that's really fundamental to protecting people from infection, is understanding actually how it's transmitted. And we were told early on by the WHO and many countries that SARS CoV2 was spread by droplets and contact. And in fact, this was just an assumption right from the outset. It wasn't based on any data. In fact, there's been studies that have shown that transmission is predominantly from the respiratory route, but also it can occur through fecal aerosolization, possibly through fomites, through the eye. It's even been documented in blood, and vertical transmission from mother to baby has been documented. Where the virus binds, or where the ACE2 inhibitors that bind the virus are present in the body, helps us understand the risk. So it's the receptor that binds the virus is present all through the body, in the respiratory tract, but also in the eyes, in the central nervous system, in the blood vessels, in the lungs, in the liver, and in the kidneys, and also in the heart, which explains why it causes direct damage to the heart, causes a vascular syndrome with thrombosis, embolism, heart attacks, strokes, etc. So how do you, one of the questions we should ask is, how do you prove that it's spread through contact or large droplets, which is what a lot of people are saying. The distance between 2 people, the infected and the infectee, doesn't prove that it's droplets. On the other hand, how do you prove airborne spread? Well, you can look at outbreaks where infections have occurred without close contact, and you can detect virus in air samples. I thought I'd just also mention super spreading versus secondary household transmission, because there's a lot of talk about super spreading being the main mode of transmission. It's actually, there certainly are studies that show super spreading, and super spreading particularly occurs inside indoor settings, which is typically the workplace. But then again, you look at so there are some studies that say that something like 80% of transmissions occur through super spreading, and a lot of infected cases don't infect anyone. That's kind of contradicted by the number of studies that have looked at secondary attack rates in household contacts, and it pretty consistently shows about 25% of people in a household will become infected if there is someone infected in there. So that kind of contradicts the super spreading theory that most transmission is through super spreading. Most transmission, in fact, is in the household. This is a study. Each of these graphs is a different patient, and it shows you 3 different sites of sampling. The sputum is the orange, the throat swab or the nose swab is the yellow, and the grey is the stool swab. And you can see that in most people, the highest amount of virus is in the sputum, which is coming from deep in the lungs. And that's telling you that the virus load is higher in the lower respiratory tract than in the nose and throat, which again supports airborne transmission rather than droplet transmission. The other issue is that a lot of transmission occurs before the onset of symptoms, or from people who never develop symptoms. A lot of studies have looked at this, and probably about half of all infections are in people who never develop symptoms. And about close to half of transmissions are from people without symptoms. Either they are pre-symptomatic, so they will develop symptoms but haven't yet, or they're completely asymptomatic. And the other important research finding is that the amount of virus in the respiratory tract is highest 48 hours before symptom onset and in the first 6 hours of symptoms. And also that infected people who are symptomatic and asymptomatic have the same amount of virus shedding out of their respiratory tract. So being symptomatic does not make you more infectious. And that's the thing that's really hard to control about SARS-CoV-2 transmission, because it's being transmitted from people who do not have any symptoms, who don't know they're unwell, and other people don't know they're unwell either. And they can be highly infectious. This is just a graph comparing SARS-CoV-2 with SARS-1 and seasonal influenza. And you can see that SARS-1, the reason it was essentially eradicated is that all the transmission happens when you've got symptoms and when you've got florid symptoms. So you can easily identify people who are infectious and stop them from infecting others. With influenza, you've got a small amount of people. If you look at this graph here for influenza, this little bit of the tail there is pre-symptomatic transmission. So again, it's difficult to stop the transmission. It's also got a very short incubation period. But with SARS-CoV-2, these are the possible distributions. So you've got a massive amount of transmission occurring before the onset of symptoms. So this paradigm of droplet versus airborne spread is just a belief. You know, it's a belief like believing the earth is flat. It's a belief that large droplets are emitted close to the patients and small droplet nuclei at a greater distance. And that's what gives us this 3 to 6 foot or 1 to 2 meter rule. And it's driven hospital infection control practice for more than 80 years. And it's actually based on some experiments from aerobiologists from the 1940s using very, very blunt instruments, as you can imagine the cameras were back then. Newer research shows that both small and large droplets can be present close to the patient, and that large droplets can travel far further than 6 feet or 2 meters. The WHO classifies large droplets as greater than or less than 5 microns, but in actual fact, the research supports 100 microns as the better classifier, because droplets smaller than 100 microns are airborne. I think this 1 to 2 meter rules is something that just got lost in transmission a long time ago, and it's been perpetuated, just like saying the earth is flat, which is this study which looked at the time taken for large droplets to fall 2 meters vertically by William Wells, who's one of the leading aerobiologists of the 1940s. And I think somehow that the 2 meter rule or the 6 feet rule comes from this, which is a complete loss in translation. That's not what the research was about at all. We did looked at all the evidence that was available on how far do large droplets travel horizontally. And these are all the studies. There's not a lot of them, but most of them show, here's the 2 meters and the 6 feet. Most of them show that droplets travel further than 2 meters, sometimes up to 8 meters. So telling people keep 2 meters spatial separation and you'll be fine is actually not correct. Really, the transmission about SARS-CoV-2 is about the air we breathe. Aerosolization happens just when we breathe. It happens when we talk, when we sing, when we shout, when we cough or sneeze, and also when you flush the toilet. In infection control, there's a belief, again, that transmission is a ballistic event and that only things like coughing and sneezing matter, and aerosol generating medical procedures. And it's a belief that there's a ballistic event. You cough, a big droplet comes out and it lands on your eye or in your nose or in your mouth, and that's it, you get infected, which is, again, highly unlikely. It may happen occasionally, but it's much more likely that you're just breathing in accumulated aerosols in the air. Aerosolized material can also be deposited on surfaces and re-aerosolized by human activity, and aerosols accumulate in closed settings. It's exactly like cigarette smoke. If you think of cigarette smoke in a closed room, the more someone's smoking in there, the more the smoke accumulates, and you can see it and you can smell it. With respiratory aerosols, you can't see it and you can't smell it, but it accumulates in exactly the same way, and ventilation disperses those aerosols. If you open a window, if you have an air purifier, you can get rid of those aerosols and bring the risk right down. Breathing is an aerosol generating procedure, and it's been estimated that 1 minute of loud speaking can produce thousands of droplets per second and at least 1,000 virus-containing airborne particles from infected people. And when you think about it, if you're in a room, whether you're a healthcare worker or a hotel quarantine worker or an aged care worker, when you're in a room where there's somebody who might be infected and you don't know that, but there is someone who's infected in there, they breathe and speak far more than they cough or sneeze. They might cough or sneeze once, or they may not cough or sneeze at all, but they're breathing continuously and they're speaking very frequently. So the amount of aerosol generation from breathing and speaking is probably a lot more than from a single cough or sneeze. When you've got to think about the dynamic nature of this and the volume of generation. And this is again what the infection control people get wrong. They think of it as a single ballistic event only occurring from a cough and a sneeze. This is a study from school classrooms showing that the red is the hard line is the concentration of RNA particles, and the dotted line is the inhaled concentration, and the red is without an air purifier. So that's a purifier with a HEPA filter that's filtering the air and removing particles, and the blue is with a purifier. So you can see what a dramatic difference in the classroom it makes. But the other important thing it shows is that the aerosols accumulate over time. So if you're in the room for 10 minutes, your risk is not that great. But if you're in the room for 1 hour or 2 hours, your risk just keeps going up in a linear fashion. So that for a health worker who's in the ICU for 8 hours, that's a huge risk. So the term aerosol generating procedures became popular after the 2003 SARS epidemic, when a small retrospective study found an association between transmission to health workers and the use of things like endotracheal intubation and non-invasive ventilation. This is weak evidence that has been misused. And there's a nice paper in the BMJ this year by Nicholas Wilson, which outlines why we need to think more broadly about aerosol generation than just AGPs. So breathing, speaking, shouting, coughing, sneezing, flushing, and medical procedures are all aerosol generating procedures. And this is a visualization we've done of things droplets you wouldn't see with the naked eye, just from speaking. There's another study that's shown that actually a cough generates more aerosol than endotracheal intubation. And yet in Australia, for example, our PPE guidelines say that you only get an N95 respirator if you're doing an aerosol generating procedure. So you can be in a hospital ward with a patient who's coughing all the time, talking and breathing, generating a lot more aerosols than the endotracheal intubation, but you have to wear a surgical mask. We did do a study some years ago looking at the risk of aerosol generating procedures, and it is that study showed a higher risk, about 3 times the risk if you were doing high risk procedures. So the evidence is kind of mixed. There's no denying that it is a risk to do something that's going to make people cough, but there's other aerosol generation that's going on that's significant as well. The other thing is that most studies that have looked have found widespread contamination with SARS CoV2 in hospitals, even in areas quite far from the patient. Particles have been found in particles greater than 4 microns. And the peak concentration of SARS CoV2 in air appears to be in 2 size ranges, 0.25 to 1 micron and greater than 2.5 microns. So the 0.25 to 1 micron is not going to get filtered by your usual N95s, which is why you need the ventilation piece of the picture also happening. This is one of those studies that just shows how widely the contamination is there and everywhere where they found virus, including the air exhaust vents. This is just a summary of some of those studies that have looked at SARS-CoV-2 in the air. The first 6 studies are hospital studies, and all of them found virus on the air vents. 2 of them found viable virus in the air, and 5 of them found viral RNA in the air. And 2 of them found it at greater distances than 2 meters from the patient, or 6 feet, and also that it's highest in the early in the illness, which is consistent with the other data that I mentioned. The other studies, except the last one, are experimental studies, which 3 of which showed viable virus in the air 16 hours, up to 16 hours after the aerosolization. And this study in Bergamo in Italy found viral RNA in the air during the peak of the first wave there in Italy in an industrial complex. The air sampling method in these studies matters, and a lot of those studies that didn't find viable virus actually didn't use methods that will damage the virus, whereas this study by Lednicki et al. Used a method that preserves the virus, and they showed viable virus in the air. This is another study which showed, again, it's showing through electron microscopy the full virus particles, viable virus on the left, and on the right you can see the spray factor, which is an indicator of the amount of aerosolization or the propensity for aerosolization. And the green is SARS-CoV-2, the blue is SARS, and the red is MERS coronavirus. And you can see that SARS-CoV-2 has more of a propensity for aerosolization than SARS or MERS, of which are both accepted as airborne. There's just been this consistent denial of airborne transmission of SARS-CoV-2. There's also the other way to determine airborne transmission is looking at outbreaks. And I won't go through all this, but there's just been heaps and heaps of outbreaks, much more than what's shown on this slide, that show transmission to people with no close contact in closed settings, whether it's restaurants, buses, shopping malls, choirs, or in prisons. It's been shown over and over again, and very high attack rates in some cases. In the choir in the US, it was 86% of people got infected in a 2.5-hour rehearsal. There's been a number of aeroplane studies as well. In this one, the orange shows you where the COVID cases were. The dark orange, and you can see it's quite widespread. My guess is the galleys are here. My guess is it's related to the toilets. That the toilets are the common factor, because that's quite a long distance between the infectious case. Of course, yesterday in Sydney, we heard that a shuttle driver who was driving aircrew from the airport to their hotels became infected. And if most of these shuttle buses look like this, they've got no windows that can be opened, right? So that driver is sitting in there for hours on end while they're shuttling people back and forth inside a closed vehicle without windows that can be opened. And in the case reported yesterday in Sydney, the driver was wearing a surgical mask, so he became infected despite wearing a surgical mask. I'll briefly mention toilets. Studies have shown that when you flush the toilet with the lid open, there's massive upward transport of virus aerosol particles. 40 to 60% of the particles rise above the toilet seat, leading to large-scale virus spread indoors. And it's also been documented both in SARS and SARS-CoV-2 of transmission through an entire building, through the bathroom plumbing. Another study showed 4 times the risk of infection in household contacts if the index case had diarrhea. And there's been an aircraft outbreak where the toilet was documented as a main risk factor. So for the workplace, the lid should be kept down when flushing, the windows should be opened if possible, the vents should be on, and disinfectant, as in sprayed disinfectant, should be used regularly in toilets. This is that study that showed fecal aerosol transmission of SARS-CoV-2 in a high-rise building, and they basically found it went from the 15th floor to the 26th and 27th floor, but also there was a vacant apartment directly above the apartment on the 15th floor where there were infected people, and they found virus everywhere in the bathroom in this vacant apartment, all over the surfaces. So, you know, it's a real risk. There's another study here which used the Jones-Brosso criteria for determining the plausibility of aerosol or airborne transmission. And SARS-CoV-2 sits up there with tuberculosis with a score of 8 out of 9 for the weight of evidence for airborne transmission. Ventilation really matters, and Lydia Morawska, who's an expert in this area, has a nice paper mentioned here, which explains why it matters, and that really opening a window or using portable air cleaners, UV lamps as well, can reduce that risk. The normal air conditioners in households, for example, and I did see a so-called expert write about ventilation recently in the media, and they said, "Oh, just put your household air conditioner onto fresh air." Well, 99.9% of household air conditioners cannot pull in fresh air, they just recirculate. Buildings built in the last 5 years in Australia can bring in fresh air, but often management is reluctant to do that, to change the amount of fresh air coming in, because it's more expensive. It's more expensive to bring in fresh air. The temperature then has to be set on that air, etc., which is why you find reluctance of building management often to improve the ventilation inside buildings. We've heard in Australia in the last week that hotel quarantine breach and infection identified that the ventilation was really poor in the hotel corridors, you know, and I think in hotel quarantine, we've seen consistent victim blaming when security guards or cleaners or other people working in the hotel quarantine setting getting infected. They're blamed, and it's said that they did something wrong, but in actual fact, they're working in a really high-risk occupational setting. There is going to be virus in the air because there's a lot of infected people coming in from overseas. And the hotel corridors, especially in buildings built, you know, not built in the last 5 years, or buildings that have windows that cannot be opened, the hotel corridors and elevators will have accumulation of aerosols, and it's very high risk. And until we acknowledge that risk and protect people in those settings, we're going to keep seeing infections. There's ways that you can kind of look at the risk, and by how many people are in the setting, are they wearing face coverings, are they not wearing face coverings, how good is the ventilation, and you can work out risk, and that's a good way for occupational settings to look at risk. But in summary, airborne transmission is real. The WHO did modify its position to accept airborne transmission in indoor settings in July. But in Australia, we keep seeing a huge denial of airborne transmission, which is going to continue we're going to continue to see outbreaks as a result. We accept measles, TB and smallpox as airborne, but none of those pathogens were ever isolated from the air. In contrast, SARS-CoV-2 has been isolated from the air in several studies. There's just so much evidence of airborne transmission. To deny it is to deny science. And we see high rates of infection in health workers who are not given airborne precautions. There's been a bunch of ridiculous arguments against airborne transmission and shifting goalposts, like saying that the R0 proves. I won't go into why that's a nonsense argument, but it is nonsense. First, we were told that it's not airborne. Then when studies started showing viral RNA in air samples, it was said viral RNA doesn't prove infectiousness. Then when studies showed viable virus in the air, they were saying, oh, it's not infectious enough. And then they've shifted to this stupid R0 argument. Anyway, I won't go into that because I'm probably coming close to time. Just want to show here healthcare workers in Victoria on the left going to work during the second wave in a flimsy little gown, a surgical mask and a shield. And there's the cleaners going into a gym where there was one case of SARS-CoV-2 who's since subsequently left the building, and somebody is looking after their work health and safety because they're being given PAPRs or, you know, elastomeric respirators, Tyvek suits, etc. Someone is looking after them, but these healthcare workers are not being looked after. I'll skip this because you know all of this. Only just mention that with SARS-CoV-2, elimination is not possible for health workers because the hazard is the job. There's no, you can't say to them, go and treat diabetes instead, you know. The health workers have to go in and treat people with SARS-CoV-2. It's their job. So you cannot eliminate the hazard. And I think it's taken and that's an argument used, this pyramid is used as an argument against giving health workers good PPE. It's said, oh, it's the last resort, we've got to do all those things at the top of the pyramid. Even substitution is not possible for health workers. We really need to think about it differently, I think, for health workers. So the occupational risk groups, healthcare workers, including non-clinical staff like cleaning staff and ward clerks, aged care workers, clearly, hotel quarantine staff, and that hasn't yet been acknowledged. Instead, we're still victim blaming and going around in circles with kind of not acknowledging ventilation. Really, we should be selecting hotels for hotel quarantine based on their building design and the adequacy of their ventilation, but that's not happening. Other first responders, international flight crew, and I guess in high incidence settings, people who are working in retail and customer service roles. But the first three groups, health workers, aged workers, and quarantine staff, are at risk even if there's low community transmission, and we've seen that time and time again. Health workers are known to be at risk of all infections. You know, they get meningococcal disease, they get measles, they get COVID-19 because hospitals are closed indoor settings, and you know, influenza is shown to be airborne, but the airborne deniers still deny that. Hospitals are highly contaminated roles, and yet in Australia and in WHO we're seeing recommendation for surgical masks for the treatment of COVID patients. There's been a widespread failure also to provide fit testing. If you were working in mining or some other industry, you'd probably be prosecuted under work health and safety laws if you didn't do fit testing. But somehow for health workers, this kind of substandard work health and safety seems to be okay. Amnesty International reported in September, at the beginning of September, there were over 7,000 health workers dead across the world. In places like the UK, 1 in 5 health workers were infected. And this is really unacceptable. Why is it acceptable for health workers when it's not acceptable in other industries? I'll skip over that just to show that you can, in high transmission settings, you can get a lot of people coming in. This is true in obstetric service. 13%, 14% infected coming in for their routine antenatal care. But countries like Taiwan, China have had very low rates of healthcare worker infection because they've used gold standard personal protective equipment. In the UK, anaesthetists and ICU specialists who get proper respiratory protection have very low rates of infection compared to other health workers. That's just showing the difference between, you know, universal masking versus the infected person wearing a mask versus the well person wearing a mask. You dramatically reduce the risk when everyone's wearing a mask. I'll just briefly show you this, which is some of our research showing the difference between no mask, 1-layer cloth mask up here, 2-layer cloth mask and a surgical mask with speaking, coughing, sneezing, and you can see what a difference even a 1-layered cloth mask makes, right? But 2 layers is better, and a surgical mask which has 3 layers is even better. So the number of layers matters, and this is all stuff you would not see with the naked eye. This is a visualization method we've developed that allows you to see what's actually coming out with these activities. This is another study that showed that coronaviruses are highly aerosolized. They come out just with breathing. And if the person who's got the coronavirus wears a surgical mask, it stops it entirely. Lancet meta-analysis showed N95s was 96% effective against beta coronaviruses, masks 67%. Surgical masks really were designed to protect surgical wounds from infection. They don't fit or seal. And even a respirator, if it doesn't fit or seal, the air's just going to go through the gaps. You're going to be breathing in unfiltered air. The fit and the seal really matters because that's what forces the air through the filter. There's no regulation in the quality of surgical masks. They're not respiratory protection, whereas respirators are designed as respiratory protection. There's some different respirators. The disposables have the lowest protection factors, and the PAPAs have the highest. The elastomeric are very good as well. I'll skip over this. I think you know all this. You've got to fit test respirators. You can do qualitative or quantitative. I think in the pandemic, this kind of qualitative fit testing is not safe. So you need a certified occupational hygienist to come in with like a port account and do the quantitative fit testing. This is going to be an infection risk, I think, reusing a hood like this. There's been lots of trials in the past that have looked at the use of medical masks versus surgical masks, and really there's only evidence that N95s protect against other respiratory viruses. This is one of our trials, and the blue is control, the red is surgical mask, the green is N95 against different measurements of infection, and you can see there's a graded effect from nothing to surgical mask to N95. So a surgical mask probably does give you some protection, but not as much as a respirator. This is another trial we did which shows the same results, that an N95 gives significant protection, not when it's used in a targeted way, which is how it's been used in some of the US trials that are cited widely, which is where the health worker only wears the respirator when they're barrier nursing someone with flu or doing an aerosol generating procedure. In our trial, the N95 was used throughout the shift, whatever they were doing, and that is protective, but wearing it just in a targeted way is not protective. There's a summary of our trials showing the efficacy of medical masks and respirators against different outcomes, bacterial infections, influenza, and even droplet infections. And you can see that surgical masks, they probably are protective, but to a much lesser degree. None of the outcomes here reach statistical significance for the medical masks or surgical masks, but N95s are consistently significantly protective. Masks as source control, there's been a few trials there, and there is some evidence that it does protect. So just to finish off, the relevant disciplines for infection prevention and control, infection prevention and control, which is the discipline that is determining guidelines all over the world for people at risk, has arisen out of patient safety. So IPC professionals are concerned primarily about antimicrobial resistance and wound infections. The discipline is focused on patient safety, not on healthcare worker safety. And that's really what's been driving. So we've got a bunch of, hand washing experts and AMR experts driving policy for a respiratory transmissible disease. And we don't have occupational health and safety consistently at the table, looking after the needs of responders and their safety. And really the two disciplines need to be combined to give the best protection for work health and safety. The SARS Commission in Toronto, where, the same thing that's happening now happened back in 2003, where health workers in Toronto were told it's spread by droplets and contact, you can just wear a surgical mask. And of course they had a huge outbreak and healthcare workers died. And this quote was from the commissioner who reviewed the whole incident. And it talks about the precautionary principle that we shouldn't be waiting on a randomized controlled trial to show that health workers are at risk of dying if they wear a surgical mask. We need to use a precautionary principle and provide them optimal protection rather than waiting for scientific certainty. Thank you.